Hello, my name is Paul Koscumb, and I'm going to be discussing support for thrombolysis for acute stroke on DOACs, mortality and bleeding complications. About myself, I am core faculty and associate professor of emergency medicine in the Department of Emergency Medicine at the University of Texas Medical Branch in Galveston, Texas. Intravenous thrombolysis is the initial treatment for acute ischemic stroke for patients who are eligible for this therapy. Unfortunately, there is a long list of contraindications. Most relevant to this study is the use of direct oral anticoagulants, also called DOACs, within 48 hours of stroke event due to a theoretical increased risk of bleeding. The DOACs include the medications rivaroxaban, apixaban, dabigatran, and several others that are less commonly used. DOACs, over the course of the past decade, have become increasingly adopted for primary prevention of stroke in patients with non-valvular atrial fibrillation due to their favorable side effect profile and non-inferiority to other older anticoagulants, most notably the vitamin K antagonist warfarin. Unfortunately, when stroke does occur, patients on these medications are excluded from the benefits of thrombolysis. And unfortunately, even though they are non-inferior to other anticoagulants in the primary prevention of stroke, stroke does still occur at a rate of approximately 1% to 2% per patient per year. We sought to investigate whether patients who receive thrombolysis while taking direct oral anticoagulants have worsened outcomes relative to patients who receive thrombolysis and are not taking DOACs. We used the Trinetics database to perform a retrospective propensity-matched evaluation. Trinetics is a software tool that pools patient demographics from 57 healthcare organizations within the United States, with a result of 94 million patient encounters to evaluate from. We queried this database over the time period from January of 2012 through October of 2022. We identified 8,582 patients who were taking a DOAC within 48 hours of stroke who subsequently received thrombolysis. We also initially evaluated 46,703 patients not taking a DOAC within 48 hours of stroke who also subsequently received thrombolysis. However, we then subsequently performed propensity matching for age, race, ethnicity, sex, hypertension, diabetes, acute kidney failure, chronic kidney disease, overweight or obese status, heart failure, cardiac arrest, and ischemic heart disease, as these are independent risks for mortality. And after performing that match, we had a total of 17,164 acute stroke patients divided equally between the two groups that were evenly matched for these risk factors. Our outcomes were to evaluate mortality rate, frequency of intracranial hemorrhage, and need for blood transfusion as a surrogate marker for extracranial bleeding over 7 and 30 days after the initial stroke event. Our results were as follows. For mortality, patients treated with tPA, or thrombolysis, on DOACs had reduced mortality than those treated with tPA not on DOACs at both 30 days and 7 days with statistical significance, as listed in this slide. For intracranial hemorrhage, the results were similar. Patients treated with tPA on DOACs had a reduced incidence of intracranial hemorrhage than those treated with tPA not on DOACs. And again, at both 7 and 30 days, these results were statistically significant. And lastly, for blood transfusion, patients treated with tPA on DOACs had a reduced need for blood transfusion than those treated with tPA not on DOACs. And again, these results were statistically significant. The recommendation for withholding thrombolytics from patients using DOACs were first instituted in 2013 based on consensus opinion with limited to no data. These were likely prudent at the time, as the DOACs were a relatively novel class of medication. There was a single exception Patients for whom laboratory testing, which included APTT, PT, platelet count, thrombin time, or direct factor 10A activity assay was obtained and normal. However, this is a cumbersome requirement. Many of these testings, for example, direct factor 10A activity assay, is highly accurate and sensitive for the evaluation of the anticoagulant effect of DOACs. However, they're often send-up tests that cannot be obtained within a reasonable time frame. By contrast, APTT, PT, and thrombin time are sensitive to the presence of DOAC, but are not adequate at quantifying the degree of anticoagulant effect. It's basically a yes/no. Is a DOAC present? Yes. Is a DOAC providing adequate anticoagulation? Unclear. For this reason, it's not a particularly useful requirement. And despite the fact that these recommendations were instituted in 2013 based on consensus opinion with limited data, they haven't significantly been updated, and that recommendation has remained unchanged as of the most recent guidelines updated in 2019. We suspect that our decreased risk of mortality and intracranial hemorrhage is likely the result of partial efficacy of DOACs. While some patients will still experience stroke, again at a rate of approximately 1 to 2% per patient per year, the thrombus burden we suspect will be smaller due to the effect of the DOAC, which will then subsequently result in less infarction and also less risk of hemorrhagic conversion due to a lower volume of fragile tissue. The decreased need for blood transfusion, again as a surrogate marker for extracranial bleeding, we suspect is due to less debility among patients who have a stroke on a DOAC. Once again, we suspect that they are having smaller strokes, and then as a result, they are requiring less time in intensive care. It is well known, for example, that the length of ICU stay is associated with an increased risk of GI bleeds. If patients who are on DOACs are having smaller strokes, less need for hospitalization or ICU stays, then they may have less multi-system organ injury and as a result, less need for blood transfusion. In conclusion, our large multi-center retrospective study demonstrated that acute ischemic stroke patients treated with tPA who had received a DOACs within 48 hours of thrombolysis had lower mortality rate, lower risk of intracranial hemorrhage, and a lower risk of need for blood transfusion in comparison to those who were not taking DOACs. Our study suggests that the use of DOAC within 48 hours of stroke should not be a contraindication to thrombolysis for acute ischemic stroke. This is myself, as well as my co-authors. And this is my contact information. If you have any questions, please feel free to reach out to me. I thank you for your attention, and I hope you have a wonderful rest of TCEP.